All right, so we are officially started for chemistry. So there is going to be 2 PowerPoints that I'll email out to you guys afterwards with the recording link. One of them is this big review PowerPoint. I am not going to go through that today because, like I said, you guys have been through a lot of review already, but I'm going to send it to you because it has some great information in it. So I would just use it for, you know, looking into, just reading through it again, remembering some of this information. If you have certain parts of chemistry that you don't know as well as other parts, like say you really struggle on blood gases, there's a whole section about blood gases here. So maybe you can look at that and kind of get to remember some things there. You know, maybe you struggle on other things like calculations, you know, those are all in here, you know, that kind of stuff. So you can see there's a lot of great information. So it's just kind of a mashup of a bunch of different lecture PowerPoints and information pulled together from clinical chem. So I will email this to you. I'm just not going to go through it for the sake of time. It is 111 slides a lecture. So we're going to say that you can use it as another resource. All right, so we are going to go through a chemistry review question PowerPoint. And again, I will send this to you as well. It has both the question and the answers on it, which can be super helpful. And again, we'll just put in, let's see here. Usually I have you guys just put in the chat box your answers to it. I can't see, oh Lord. All right, I apologize. Okay, so let's get started on our first questions here. So just put in the chat if you want to, your answer. I'm going to go fairly quickly in the sake of time. We do have a lot of slides to get through. So if, and then if you don't want to answer, you don't have to, but you know, it's okay to be wrong. Everybody's wrong at these questions at times. All right, so hemolysis can cause an increase in which of the following measurements? So is it glucose, albumin, chloride, or potassium? Which one is increased by hemolysis? And I just have to flip back and forth to see the answers here. So yeah, I'm already seeing D, potassium, definitely is the right answer. So potassium, of course, the minute that we have a high potassium in the chemistry department, one thing you should always check for is, was the sample really hemolyzed? Most analyzers have like a hemolysis icteric and lipemic indicators that they will flag it if hemolysis is what caused it to be high potentially, but you can always visually look at the sample as well. Hyperalbuminemia is caused by what? Only one thing will ever cause a high albumin, or what we call hyperalbuminemia. What was it? Let me look at the answers here. Yeah, so A, dehydration, good. So yep, that is the only thing that we know that causes a high albumin is dehydration. So good. Okay, thank you, Indra. I'm glad to see that you're with us in spirit here. You can hear us. Okay. Which one of the following enzymes produced by the pancreas is the most specific for detecting acute pancreatitis? So which enzyme made by the pancreas is the best at detecting acute pancreatitis? So amylase, GGT, lipase, or pancreatase. It's a hard word to say. All right, so I have some A's here. So a lot of people said, I think they said amylase. Amylase is used a lot for pancreatic stuff like pancreatitis, but it is not the most specific out of the bunch, and it's not made by the pancreas. Amylase is found in a few places in your body, like your salivary glands, that kind of thing. So if you think of it that way, it's not the most specific. There is something better than amylase for detecting pancreatitis. And so that would be lipase, yes. So lipase is the best for looking at pancreatitis. Amylase is a good one, it's used, but it's not the most specific. And so lipase is made by the pancreas. Okay. Which one of the following enzymes is considered a sensitive marker for chronic alcoholic liver disease? So which enzyme is a good marker for alcoholic liver disease? ALP, GGT, albumin, or AST? Let's see what people are answering. I've got B's for GGT, yes. So we've all kind of learned I guess I can show the answer. Oops, no, that one, not, oh, geez, Lori. Having a Monday. Yes, GGT is the liver enzyme that's best for alcoholism. I know that Becky, the old MLT coordinator in Green Bay, had it saying, go get tequila. To remember that, GGT, go get tequila, for remembering that one with the alcoholism. All right, the CK isoform that is considered as most cardiac specific is what? Which one is most cardiac specific? So we have CKMM, CKMB, CKBB, or total CK. Okay, I have a couple of guesses now. So yes, it is CKMB. I know when I was first starting out, we used CKMB with troponin a lot for cardiac patients, especially that were coming in through the ER. I worked in a smaller lab. I don't know if a lot of labs use CKMB. I've worked in labs that never run CKMB, so I don't even have it on hand. And then I've worked in labs that always run CKMBs with the troponins. We all know that troponin is our best marker for cardiac arrest for heart attacks, but CKMB was once upon a time used just along with it, and it just depends on what lab you go to now, what they use. A non-specific response to inflammation that includes elevation of certain proteins and decrease of others due to cytokine production is referred to as what? A non-specific response to inflammation that elevates certain plasma proteins and decreases others is what? Yes, so it is acute phase reaction, so APR proteins. We talk a lot about those. We talked about those in hematology, in immunology, and in chemistry. So those are those proteins that always respond to inflammation and increase in their response to that inflammation. All right, the plasma protein that demonstrates an increased concentration in iron deficiency anemia is, so what one is increased in iron deficiency anemia? Sorry. All right, so I'm seeing some transferrin. It is transferrin. So when we have iron deficiency, we increase the level of transferrin because we want it to transport our iron. We want as much iron as we can get because we're deficient in it. So that is correct. It would be transferrin. Haptoglobin is involved with some stuff with hemoglobin stuff, but it's more involved with hemolysis stuff. So that doesn't apply here for iron deficiency. So it is transferrin. Increased maternal serum concentration of which protein is observed with the presence of multiple fetuses like twins? Increased maternal serum of what protein is increased with the presence of twins? All right, good. Some good guesses. Yep. And it should be alpha-1 fetoprotein. The nice thing is feto for fetus is right in the name of it, alpha-1 fetoprotein. So it kind of indicates it goes with that. Urea is made from what? What is urea produced from? Okay, let me take a look here. We have a few guesses. So it is the breakdown of proteins and amino acids. So BUN or urea is made from the breakdown of proteins and amino acids. I don't know why I keep doing that. Okay, creatinine clearance is a measure of the blank of a patient. So creatinine clearance measures what? Good. Everybody looks like they got this one. It is the glomerular filtration rate. Perfect. The GFR. Conversion of glucose into lactate or pyruvate is referred to as what? Converting glucose into lactate or pyruvate is called what? please. I don't think everybody's answered yet. I was going to give it a second. Okay. I don't know if everybody's answered or not, but these little words can be tricky because they're easily confused with each other. I was just making sure I was still recording. So it is actually D on this one, glycolysis. So the way that I remember these darn little words, and I will kind of type this in the notes. So let me make this, my notes area bigger here. So I look at the word itself, and I use what the word is made up of to let me know what it is. So that first answer choice was glycogenesis. So when I look at it, Genesis is the first book in the Bible, in the Christian Bible, and Genesis always means like creation. They're creating the worlds in that book. So I always think of, okay, Genesis is creation. So then I think of glycogen is right in the word as well, glycogenesis. So glycogen is your stored form of glucose. So I know that that glycogenesis term means I'm creating glycogen. I'm going to move glucose out of the bloodstream into storage and make it glycogen. So I'm creating glycogen. So that's what glycogenesis is they're creating glycogen. Gluconeogenesis is the next word here. So again, I have Genesis, so I know I have creation. So I'm going to create something. Then I have the term gluco, which of course stands for glucose. And then I have neo. This one's kind of weird, but the way I remember neo is I think of neo as new. Why I keep typing a 0? There we go. As new. So I'm going to create glucose from a new source is the way I think of it. So gluconeogenesis is when you can make glucose from amino acids or other things. They're going to take a different type of source and make glucose because they don't have the specific normal glucose available to them. So they're going to create glucose from a different new source. So that's gluconeogenesis. Glycogenolysis is the next choice. So in this case, you have lysis, which means breakdown or destruction. And then you have, again, the word glycogen in there. So I know we're going to break down glycogen. And when you break down your glycogen, you're putting it back into glucose because that's what the glycogen is made from, is glucose. So we'll break down the glycogen and it will turn back into glucose. So that is that term. And so for this question, the term was glycolysis. And so this is saying you're creating glucose into lactate or pyruvate. So this is the only term that my little theory doesn't work nicely with. So this is dumb, but the way I remember it, I always remember this is the oddball out. So this is the one that goes with lactate or pyruvate, the weird one. So glycolysis is the breakdown. Again, you're converting, in this case, glucose into lactate or pyruvate. So breaking it down into that, if you will. So again, my theory doesn't work nicely with this term, but it works well with the others. So if I can remember the others, I can remember this is the oddball one out. That might not even help you. That might be more confusing to you. You have to do what you can to memorize these dang little terms. So that's just kind of how I do it, is I just try to use the parts of the word to tell me what it makes. So, all right. Back to making that bigger. Okay. Let's keep going. All right. Cholesterol is transported in the blood as cholesterol esters, mainly in what form? So how is cholesterol mainly transported? All right. So in this case, it is LDL. LDL, which is what we always call our bad cholesterol. And that's because if people have too much LDL, that means they're carrying around way too much cholesterol, more than they need, because it's bringing more and more cholesterol into your body. So if you think of it that way, LDL has always been the bad cholesterol, and that's because it carries the main amount of our cholesterol into us. HDL was the good cholesterol because it got rid of the extra cholesterol, removed it out of us. So that's why we like HDL, because it gets rid of the extra. LDL is bad because you want some of it, but you don't want a lot because it's bringing in all this extra cholesterol. It carries it. Okay, by what mechanism does glucagon promote hyperglycemia? So what way does glucagon make us have high glucose levels, hyperglycemia? It takes a while to read through the choices. Okay, I see some answers here. I'll go back. Oh. So this one is kind of a little bit of a critical thinking one, because you got to go through and understand what each of these means. All right, so let's do this. It is C. So glucagon is a hormone that will have us get a high blood sugar, high glucose level, which is called hyperglycemia. So when you look through these answer choices, it can, C is the right answer because glucagon stimulates glucose synthesis by gluconeogenesis, because I said before, gluconeogenesis is creating new glucose. So it's going to use other sources and create glucose for us. So that would give us high glucose levels in the blood because it's going to create it for us. The others are not going to give us high glucose. So letter A, glucagon promotes glycogenesis. That would decrease your glucose levels because that's going to make more glycogen. It's going to store the glucose. It's going to take it out of the blood and put it in storage. Well, that doesn't make high glucose. That lowers it. So that's not right. Glucagon stimulates insulin release. Remember, insulin lowers your glucose levels. That's why diabetics have high sugar. They don't have insulin. So if insulin lowers your glucose, why did this move? If it lowers the insulin, that's not going to create high glucose levels either. So that's not correct. And then the last one, that's not correct because glucagon does give us high glucose levels. So C is the way in which, one way in which it can do that. So again, you kind of had to go through each one and process what they meant. All right, a patient with severe uncontrolled case of type 1 diabetes will exhibit all of the following except what? All right, I have a couple of people that have answered, so let's take a look. And it is hyperinsulinemia. So in people that have very uncontrolled diabetes, they definitely can have high lipid levels, high glucose levels, and they can be at risk of going into ketoacidosis if it gets very severe. Letter C is not true because hyperinsulinemia is saying you have high insulin. Well, in people that are very diabetic, especially type 1 diabetes, they do not make insulin at all. That's the problem. In type 1 diabetics, they're not making insulin, so they can't have a high insulin level. So that is good. Correct. Okay. There is an inverse relationship between which one of the following cholesterol lipoproteins and an increased risk of coronary heart disease. An inverse relationship between which of the following cholesterol lipoproteins and an increased risk of coronary heart disease. Okay, so we have a couple answers, and it is D, HDL. So again, HDL is your good cholesterol. So the more HDL you have, the lower your risk of coronary heart disease, and vice versa. The less HDL you have, the higher risk of CHD. So that's where the inverse relationship, when one goes down, the other goes up. Okay, a 45-year-old woman has a fasting glucose of 95 and a 2-hour postprandial glucose concentration of 105. The statement that best describes this patient's fasting serum glucose is what? She has a serum fasting glucose of 95 and a 2-hour postprandial of 105. Okay, let me see what we got for answers here. All right, a lot of A, and that should be right. Yep, totally normal. 95 fasting is normal. I think the reference range is what, roughly 50 to 100, give or take some, 60 to 100, depending on where you work. And then 2 hours after eating at 105, that's amazing. That means their liver is doing its job. It's breaking down and storing glycogen, putting the glucose to storage. So getting it out of the bloodstream, that's good. All right. Monitoring long-term glucose control in patients with diabetes can best be accomplished by measuring what? What do we use to monitor diabetes? All right, I'm pretty sure you guys have this one. Yes, hemoglobin A1Cs, and pretty much every chemistry lab runs those. Yep, good. A fasting serum sample from an asymptomatic 43-year-old woman is examined visually and chemically with the following results. So the appearance of the serum was milky. After overnight refrigeration, it had a nice creamy layer over turbid serum. Oh, yummy. And then the triglyceride level was 2,000. The cholesterol level was 550. What is predominantly in that serum sample? This sample contains predominantly what? Zinc. All right, I think I have a couple answers. It's hard to know where I'm at in those answers. It is B, so it's definitely chylomicrons. So again, chylomicrons are what carries all your triglycerides. So anytime you see a really milkshake looking serum, they're gonna have a lot of triglycerides. So that's the chylomicrons carrying all those triglycerides. VLDL does carry exogenous cholesterol, so cholesterol that you take in from food. And a cholesterol level of 550 is very high. We always tell people we want their cholesterol levels to be less than 200. So 550, very high. So that's telling us we have a lot of VLDL carrying all that cholesterol from exogenous from the food. So in this case, she's supposed to be fasting. Obviously, she's just got a lot of lipid issues. Okay. The enzyme that exists chiefly in skeletal muscle, heart, and brain is grossly elevated in acute or active muscular dystrophy and rises early in myocardial infarction is what enzyme? What enzyme meets this description? All right, a couple things here. So in this case, it would be creatine kinase. So creatine kinase, remember you have CKMM, which is found a lot in muscles, CKMB, which is heart, CKBB, which is brain. So it's one of the very, total creatine kinase goes sky high in muscular dystrophy because creatine kinase is found in the muscles. So anything that's going to damage your muscles will cause your CK level to go really high. It is one of the very first things to rise in a heart attack and myocardial infarction. We just don't usually measure the creatine kinase. It's too general because it can be associated with a bunch of different things. But if you did, it would rise very early on. Which of the following lipid results would be expected to be elevated falsely elevated on a serum sample from a non-fasting patient. So if your patient was not fasting, what would be falsely elevated? Okay. And it would be triglycerides. So that's our main thing. The reason we always tell people to fast for lipid is not mostly, usually it's not due to cholesterol. We want them to fast because of triglyceride level will be elevated. Good. All right, which of the following represents the end product of purine metabolism in humans? What results in, after you break down purines, what does it form? Okay, I think people have been answering. It's a lot of D's and B's on the screen from other questions still. Okay, yep, it is uric acid. So remember, we already discussed urea. Urea is from the breakdown of proteins and amino acids. So your food, basically proteins and amino acids in your food will break down into urea. Uric acid is from the breakdown of purines. So anybody that is tending to form gout, which would have higher levels of uric acid, they always tell them to avoid certain foods and drinks that might have more purine levels in them so that they didn't break down so much into uric acid. I know alcohol is one that's high in purine, so then they're told not to really drink that much. Okay, lipemia in serum suggests an elevation of what? Okay. All right. It is chylomicrons. So again, chylomicrons are what is carrying the triglycerides. And so anytime you have a high level of triglycerides, which would be higher amount of chylomicrons, it'll show up as lipemic, that really milkshake look. If a patient has been fasting for 3 days, what glucose metabolism pathway is the body most likely going to go through? If they have been fasting for 3 days, what pathway are they going to use? F. All right, let's take a look. And it will be in gluconeogenesis. So again, gluconeogenesis is the creation of glucose from new sources. So if you've been fasting for 3 days, you're not putting anything in your body. So you're not putting in any glucose from food or anything. So by this point, they've used up all their sugar. They've used up their storage of sugar, their glycogen. So they're like, we need to get glucose for energy. How do we do this? So they're going to convert other things in your body to glucose instead. So again, you're creating glucose from new or other sources. All right, this analyte is seen increase in gout. This one should be pretty fast. Yeah, good. Uric acid, perfect. Pretty much the only reason we usually measure that. AST and ALT are both elevated in which of the following diseases? good. I think everybody's got this. Yep, viral hepatitis. So anything liver related would cause your AST, ALT to pretty much go high. There's a couple things that might not, but ALT is by far your most specific liver enzyme. AST can be found in other places in your body. So it's a good liver enzyme, but it can be found some other spots too. But ALT is for sure your big liver enzyme. Which of the following is seen elevated in Ray's syndrome? Okay, I see a lot of good answers here. And it is ammonia. So this is the reason why children are not allowed to take aspirin. Aspirin can result in a Ray's syndrome. So that's why they're told Tylenol or ibuprofen. Okay, the Reagan isoenzyme has the same properties as alkaline phosphatase, which is ALP, that originates in what place? So Reagan isoenzyme, it's an isoenzyme of ALP. Where does it come from? Yeah, this one's usually harder for people, mainly because they probably don't remember it if they ever did learn it. If you learned it, it was like one little blip about it. So ALP, which is another liver enzyme, it has different isoenzymes because it's not only a liver enzyme, but it's also found in the bones. In this case, the Reagan isoenzyme is also found in the placenta. So it does have a few other things that it's involved with. The way that I always remember this, and again, it's dumb, but it works for me, is that I always think of Reagan as sounding like a little baby's name because I knew, well, now she's grown up, but I knew a kid named Reagan. So I always thought, okay, baby Reagan. So then I always thought of placenta. That's just what stuck with me. Okay, which porphyrin is primarily found to be excreted in the feces? Okay, and porphyrins are usually not, so they're tricky. This one, it is protoporphyrin. In the scope of all of chemistry and what you have to remember and know for like your final exam and for the boards, I would not worry about porphyrins. If you cannot fit porphyrins into your brain, don't put them in there. Worry about the enzymes, the proteins, the, you know, all the other test markers and diseases associated with them, the electrolytes, all that stuff. I put learning and remembering porphyrins last. So just as an FYI, if you had to dump something, dump the porphyrins out of your brain. I'd like you to know them, but again, you can't remember everything. To me, they're probably the least of our worries in chemistry. Okay, this trace element plays a key role in protein and nucleic acid synthesis. All right, I think everybody got this one, which is awesome. It is zinc, and many of you might take zinc over the counter. I know a lot of people do as a vitamin that they like to take, so it's good for you. Okay, total iron binding capacity, TIBC, measures the serum iron transporting capacity of what protein? All right, and this is transferrin. So the nice thing about transferrin is it's named for exactly what it does. Transport, ferrin for iron. That's its whole role, transporting iron. Okay. Specimens for blood gas should be drawn into a syringe containing what? Okay, I think everybody answered. And it is heparin. So heparin is our main anticoagulant in the chemistry area. So that should be easy to associate with. We would also put blood gases in a syringe with heparin. Keeps it from clotting. Just out of curiosity, did anybody do blood gases? Did anybody get to draw any? I know a lot of times they don't have new students draw them, but you might go and see one done. Every hospital is different. I'm just curious. Observed one. I hate drawing them, by the way, so if you can work somewhere where you don't have to draw one, it'd be great. I drew venous ones. Yes, there are venous blood gases done. I worked at hospitals that do both. Yeah, they're a lot nicer to do. That's a good experience, Dallas. I was just curious if anybody, so every hospital is different. I've worked in hospitals that lab always did blood gas drawing and ran them. And then I worked in hospitals that had a respiratory therapy unit, and then they did it, so you didn't have to. And then I worked at a hospital where they had a respiratory therapy unit, but the lab still did the blood gas drawing and running the analyzer. So it varies everywhere you go, but just curious. Okay. All right. Which of the following is the correct formula for Henderson-Hasselbalch? When they're like this is really hard to tell them apart because it's like, oh my God, what one is it? Just do your best. It's a pure memorization thing for knowing which one was the formula. Okay, so we have a few guesses because it's hard to pick it out when it's lined up like this. It is D. So pKa plus the log of base over acid. So again, it's just memorizing it. You do not need to know how to calculate it, just memorize it. All right, getting into blood gas stuff, which I actually really love blood gases. They're kind of like puzzles to me. So metabolic acidosis results in what? All right, I have a couple things. Usually people start to kind of forget this stuff. That's okay. All right. So let's see. Okay, I'm going to reveal the answer. All right, so it is primary bicarb deficit. So here's the deal. You always have metabolic or respiratory, acidosis or alkalosis. Those are your kind of categories. Metabolic always deals with bicarbonate stuff. Respiratory deals with carbon dioxide, what you breathe out. So metabolic, the minute you see that word, you're thinking something's up with the bicarbonate. Now, bicarbonate in your body is a base. So if you have a lot of bicarb, it would make your pH alkaline because you have too much base. If you have little or a deficit in bicarb, your pH would become acidic because you don't have enough base. It would drop the pH into an acidic level. So if you can remember that, you can remember then, okay, metabolic, dealing with bicarbonate. Acidosis, well, it means that we don't have enough base. It dropped it too low of a pH, so it's a deficit. So then with respiratory, again, if I would have said respiratory acidosis, then you'd be like respiratory is carbon dioxide. And you have to think about carbon dioxide instead. And carbon dioxide is an acid in your body. So your acid is carbon dioxide, bicarbonate is your base. Carbon dioxide is dealing with respiratory, bicarb is dealing with metabolic. So that's kind of starting to piece them together that way. Okay, so we have our first case. I'm going to walk through this with you guys. So it's giving you some values here, and you have to determine which of the four categories they are in, if they're respiratory or metabolic, and if they're acidosis or alkalosis. So first, you got to know reference ranges. So I'm going to give you what I always use as reference ranges because they're nice, easy, even numbers. So I know a pH to be between 7.35 to 7.45. That is, and I can't type apparently. There, that's a normal pH range of blood, 7.35 to 7.45. I know our CO2 level should be roughly 35 to 45. Again, nice even numbers. It kind of matches the pH numbers there. So CO2, 35 to 45 is normal. I know that your bicarbonate, if they give you one, sometimes they don't always give you a bicarbonate number, is 22 to 32 roughly. That should be a nice normal range. Again, nice even numbers. If they give you oxygen, that should always be 80 to 100, so it should be above 80. So those are kind of some reference ranges to have on hand. So now I'm going to make the slide bigger again so I can see it. So I'm going to lower those down there. Okay. So when you first deal with numbers and you got to figure out what this person has, the first thing you do is look at the pH. That's the easiest thing to figure out. So a pH of 7.48 is alkaline. It is high. So we can rule out any of the acidic choices. We know it's not one of those. So it's an alkaline pH. Now they gave you the CO2, they gave you oxygen, they gave you what we call base excess. They didn't give us a bicarb, but base excess represents base. Like it represents the bicarb in this place, which is neutral. So here we already see that our oxygen is low at 65 on room air. So we pretty much know it's a respiratory issue. So we know that the pH was alkalosis. I'm going to write that beside it because it was high. So now let's see if it makes sense. Does it make sense for it to be a respiratory alkalosis? Because respiratory, since your oxygen is low, let's look at our CO2, 31. So 31 is low because the range is 35 to 45. And again, your CO2 is an acid. So if you have a low amount of acid, that would put you into an alkaline pH. That would cause your pH to go up because you don't have enough acid to balance it out. So in this case, this would be a respiratory alkalosis. So hopefully, I think we have a few other practice problems in here at points, so hopefully you can follow that. I see, Dallas, you wrote out the answer too. Good. So to me, they're like puzzles. So if you remember your reference ranges, that helps. And then you first start with the pH and determine what that is, and then you can figure out, okay, what's the cause? Is it the CO2 that's off, or is it the bicarb or base that's off? And then you can kind of figure out if it's respiratory or metabolic. All right. So what is one cause of a respiratory alkalosis? So what would put us into a respiratory alkalosis? I know people are still answering. Okay, I think enough have answered. And so in this case, salicylate poisoning would be one cause of respiratory alkalosis. If you bear with me one second, let me find, I wanted to show something. Once upon a time, I used to teach chemistry. It's hard to believe, I know. But I had my own PowerPoints as a result. You can see it's back from 2010. My God, that's a long time ago that I used my own PowerPoints. So when I taught, I made this PowerPoint back in 2010, and I wanted to show you a chart, and I can send this to you guys. So I had this chart on what disorders would cause us to have each of the categories. So in this case, we talked about respiratory alkalosis, and right here is salicylate poisoning. So I kind of had this as, it's a memorization thing. Unfortunately, there's not a way to always, I mean, you can go into depth on why each one puts you where it does, or you can just memorize it. So like in the respiratory alkalosis, hysteria, fever, salicylate poisoning, severe asthma would all cause respiratory alkalosis. In the respiratory acidosis, it would be other lung stuff. And then you can see in the metabolic world, it's other stuff. So I can definitely send you this PowerPoint if you want this chart specifically from there. It is kind of handy to have. So just as an FYI. Salicylate is aspirin, yes. So aspirin poisoning, yep. All right. Well, let me see here. Where were we at? Okay. What is one way that the body will compensate then for having respiratory alkalosis? So your body's got to get your pH back to normal. How can it compensate and do this? Okay, let's see what we got here. Oh, Dallas, I see your other question. Not necessarily. I mean, maybe a side effect of rays could be like in respiratory alkalosis, because you're thinking of, I said that's why babies can't take aspirin because the buildup of ammonia. I don't know. That's a hard question. I would keep it separate in my mind, but it's a good thought process. It could be. I haven't looked into it to tell you the truth, so I don't have a great answer for you on that. I'm sorry. It's an interesting thought. Yeah. Okay, so in this case, hyperventilation will compensate. So think of it this way. So we already said that respiratory alkalosis is not enough CO2, not enough acid. If you hyperventilate, you're going to create a lot more CO2. You're going to create that acid into your body by hyperventilating. So it'll lower that pH back out of the alkaline area back down into hopefully the normal area. So by hyperventilating, you're going to create that CO2 acid that you need, that you're missing, that you're low in. So that is one way your body might react to it. Okay. Delete. All right. Here is another case study. So I'll have you guys kind of work through this one on your own. So determine which category it is in. So you have your values, start with the pH, and then go from there. If you guys need any reference ranges, let me know. I'm going to give you a minute here. Okay, so I see quite a few people have answered, and sorry if not everybody got through it. I'm so excited. You guys are getting it. It is metabolic acidosis. So starting with that pH, it is low, so it's acidic. So right away we know it's an acidosis. Our CO2 is slightly low. Our room air is good. Our oxygen's good. Your base excess is -16. So it's telling us we have a lot of base excess, base excess at -16, sorry, meaning we have little base, not a lot. Negative is little. Math is not my strong suit. So we know it's a metabolic issue when your base is so heavily affected. So little base, meaning your pH dropped way into the acidic range because you didn't have enough base. So it's definitely a metabolic acidosis. Now, the reason the CO2 here is slightly low is your body's already trying to compensate. It's trying to get rid of some of the acid, the CO2, so that it can hopefully get the pH to start coming back up. So that's what your body will do. If you have too acidic of a pH, it's going to try to get rid of some of the acid out of you. So that's why it's starting to drop that CO2 a little bit. All right, so then what is a cause of metabolic acidosis? Okay, so I see a few answers. So we already know that salicylate poisoning was respiratory alkalosis. We can rule that out. And so in this one, it just sounds like the way it is, lactic acidosis. So again, if I were to go to that PowerPoint chart, under the metabolic acidosis, you have a bunch of different acidic ones, and along with some chemical poisonings, and then a couple other things there. The prolonged vomiting, which is one of the other answer choices, is under metabolic alkalosis. Okay. All right. A little critical thinking time. So how would a blood gas parameter change if a sealed specimen is left at room temperature for more than 2 hours? So if you had a sealed up blood sample, how would their blood gas values changed? I'll give it a little bit longer here. I see a lot of question marks, yes. That's okay to have question marks, yeah. All right, so let's look at this. So letter C, so just think about it. If something is sealed, eventually the oxygen is going to deplete itself because it's sealed. So we know that oxygen is going to decrease, so you can right away rule it down to two answers. When your oxygen decreases, your CO2 increases as a result. CO2 is an acid, so the more CO2 you get, the more your pH is going to become acidic and drop into that acidic range, so your pH would decrease. All right, good. Okay, which of the following will cause a shift of the oxygen dissociation curve to the right, resulting in a decreased affinity of hemoglobin for oxygen? Okay, so we need to revisit probably our oxygen dissociation curve, which is kind of a crossover from heme to chemistry. So in this case, an acidic or low pH would cause a curve to the right. So if I go back to my same PowerPoint that I've been referencing for those acid-base disorders, I should also have oxygen dissociation curve stuff. Here it is. Okay. So your oxygen curve is going to shift one way or the other depending on what happens in your body. Now, again, if it shifts to the left, it means that hemoglobin loves the oxygen. Left loves. It wants to keep it. If it shifts to the right, your hemoglobin releases, right release. It gets rid of it, no problem. Here are the things that will put it into each. So if we start with, I'm going to skip pH for now. If you start with 2,3-BPG, first you got to remember what 2,3-BPG even does, and that helps your oxygen get released off the hemoglobin molecule. So if somebody's like really anemic, you'll naturally elevate the levels of 2,3-BPG in them because they want as much oxygen out there as they can because they're anemic. So that's its whole role. Let's get the oxygen released. So anytime you increase the 2,3-BPG level, it will shift it to the right because it wants more oxygen. So then the reverse is true. If you decrease that level, it'll hang on to it. It'll love it. It'll shift it to the left. Temperature of the body. Heat breaks the bond between oxygen and hemoglobin. So if you have hot body heat, high body temp, it will break that bond easily and release the oxygen. So again, the opposite is true. If it's a colder body temp, it won't break it. It'll keep it longer. So it'll love it. Left shift. And then CO2 levels. If you have increased CO2, your body's naturally going to be like, we have too much CO2. We need more oxygen out there to balance it. So it's going to right release it. It wants more oxygen out to compete with the CO2 that's out there. And so again, the same thing. If you have little CO2 out there, that means you have too much oxygen. So we're going to hang on and love the oxygen so that we can balance it back out. It's all about balancing. All right, and now the pH. Well, if you link the pH with the CO2, it's easy. So CO2 is an acid. If you have a lot of CO2 happening, an increased amount of CO2, a lot of acid, you'll have a decreased pH. So again, we'd want to release out more oxygen, right release, to counteract all that acid that is out there and happening. So somehow you have to memorize this. And so if you can always, you can either understand and know what each thing means, like I just explained, which can be a lot to get, or you have to memorize it. And so if you do this, the 2,3-BPG, the temperature, and the CO2 all go in the same direction on each one. Like on the left side, they all decrease. On the right side, they all increase. The pH is the only one that's always opposite of that. So the way you can think about this is an increased pH is alkaline, and I always know there's two L's in alkaline, so L for left. And so then I know the opposite is true, is acid is right. Whatever technique works for you to get this down. So if we go from this back to the question, so what one would curve it to the right, an acidic pH level, a low pH level would, because there's a lot of acid, a lot of CO2, we want to get more oxygen out there, right release. And so again, A decreased pH would put you in the right shift. Okay. It does take some time to kind of get this down. All right. In uncompensated metabolic acidosis, which of the following is normal? So in metabolic acidosis that is not being compensated yet, what is still normal? Yes. So I see a few people answer what I thought they might answer, and I totally get that all the time. But in this case, it is B. So I see B, and then I thought people would probably say C at first as well. Okay, so I'm going to explain this. So metabolic acidosis, we know the pH is not normal because it's acidic. Metabolic is always saying bicarbonate is at fault, so we know that's not normal. Bicarbonate is part of the total CO2 picture. So bicarbonate plus CO2 equals total CO2. So if the bicarbonate is abnormal, then the total CO2 is still abnormal because it's a part of it. So the only thing that has remained normal in an uncompensated metabolic is CO2. It has nothing to do with it yet. We haven't done anything with our CO2 level. It's stayed the same so far. Okay, which of the following blood gas parameters are measured directly by the analyzer? And this one can be tricky. If you've never seen this question, you probably are like, I'm just going to guess. Okay, I have a couple answers here, and it is C, the P's. pH, the partial pressure, CO2, partial pressure, oxygen. Those are what is being directly measured. The rest can be kind of calculated and interpreted. Okay, which of the following characterizes respiratory acidosis? Okay, we got a bunch of answers. And it is good. So respiratory, we knew it had to do with carbon dioxide. If it's acidic, we have lots of carbon dioxide, too much acid. Perfect. Good. Excessive carbon dioxide. All right, some electrolyte stuff. The most common lab method of sodium potassium measurement is what? I'm hoping you guys have this on your chemistry analyzer. Maybe you discussed it or dealt with it. Okay, let me see what you guys got. Okay, I think some people have answered. And it is ion selective electrodes. They're the most common way to measure sodium and potassium. A lot of times chloride is on there. Lithium might sometimes be measured that way as well. So yeah, good. ISE, ion selective electrodes. The high extracellular concentration of this cation contributes to the osmotic strength of extracellular fluid. Okay, I think everybody's kind of answered this one too, and it is sodium. So that's its main definition and main function of what it does. So sodium is our main cation in the extracellular fluid, and it definitely does contribute to the osmotic strength of it. A potassium level of 6.8 is obtained before reporting the results. The first step you should do is what out of the choices? All right, everybody's got this. Yep, look for hemolysis because 6.8 is very high, very high for potassium. Okay, calculate the anion gap. See what you guys got. I'll give it a second here. Okay. All right. I'm going to go ahead. I don't think anybody's put their answer in, and that's okay. Maybe you don't want to be the one to be like, I don't want to put my answer out there. That's fine. So you might still be also working on it. So here is the equation. So again, it's your cations, so sodium plus potassium, and then your anions, bicarb plus chloride, and then you subtract the two areas. So, and you should get roughly 6.6 in this case. So you add together your cations, add together your anions, and then subtract them to get your answer. Okay. So that is one equation you should definitely know for your boards for sure. Calculate the plasma osmolality using the following data. So this is another one of those calculations you should know for boards is your osmolality calculation. I'll give it a few seconds. I'm not going to take forever, just for you guys to look at it. Oh, you guys did start answering. Thank you. Okay, so let's go ahead and take a look just for the sake of time. So again, your osmolality calculation is 2 times your glucose plus, 2 times your sodium plus your glucose divided by 20 plus your urea divided by 3. So you kind of do each step separate, then add them together, and then you can get your final osmolality there. So just try to know that as best as you can. Again, if you don't always have every single calculation memorized, you might get one question on it on the board. Okay, which of the following lab results is usually associated with cystic fibrosis? All right, and good, you guys got it. So we can measure sweat chloride for cystic fibrosis. Anything greater than 60 would be associated with it. Good. Which of the following hormones promotes hyperglycemia? Okay, I think I have a few answers. In this case, it'd be growth hormone. So glucagon is a big one with promoting high glucose levels in the blood. Growth hormone is another one that can. The isoenzymes LD4 and LD5, which are lactate dehydrogenase 4 and 5, are elevated in what? Okay, let's take a look. and it would be liver disease in this case. So there are 5 isoenzymes to lactate dehydrogenase, and each ones kind of tend to occur in different diseases. So 4 and 5 have definitely been linked with liver disease. Elevation of amylase and lipase is commonly seen in what? Okay. I think people are going already on this. So yep, it is definitely acute pancreatitis. Because the lipase is elevated, that is very pancreatic specific. That really tells us. Now, if only amylase was elevated and lipase was normal, then I might consider it to be a possible appendicitis, because you can see an elevated amylase with appendicitis and the lipase would stay normal in that case. But because both are elevated, especially that lipase, it's pancreatitis. Which of the following can be physiologically elevated in children? So not due to a disease, just normal stuff. Physiologically, just kind of normal part of the process. Okay, so yep, it is ALP. So we know that ALP, like I'd already said, was part of our liver enzymes. It's in a liver panel, but it's also very much found with bone stuff. And so as children are growing and their bones are growing, ALP is naturally higher in them because of that growing process. Okay, calculate the creatinine, must mean creatinine clearance, given the following results. And you might have already done this in your analysis this morning. I'm not sure. So. Okay, so I know people are probably still working on this, but we're just going to keep going forward. So in this case, depending on how you round, 89.2, I think somebody said 89.47 Dallas, right? Yeah, perfectly fine. She probably rounded a bit differently than I did when I calculated it. So yeah. So, yeah, okay. So make sure you know how to do your creatinine clearance. Here's another calculation you should know. Calculate the LDL given the following values, given the following results. Okay, so I see one answer. Again, I'm just going to go ahead, plow forward, because it's actually a trick question. All right, you can't calculate your LDL whenever your triglycerides are above 400. So in the calculation for LDL, you usually have to take triglycerides divided by 5 because that's going to estimate your VLDL value. Well, anytime the triglycerides get too high, above 400, it doesn't correctly estimate anymore, so then you can't even do it. So in this case, in a lab, if this were a patient, they would have to do a direct LDL test to get that value. They can't do it. They can't have the analyzer calculate it for them. And so they'd have to do a direct LDL measurement. So it's a trick question. But here's another example that you can actually do. So you can calculate this one. All right, I have a couple guesses. Let's take a look. So the calculation is cholesterol minus your HDL plus triglycerides divided by 5. So you do what's in the parentheses first. So do the triglycerides divided by 5, add it to your HDL, and then you can subtract it from cholesterol to get, in this case, it'd be 115 for your LDL. So it just depends on the order that you do it in. That will make all the difference in the world. So you have to do the parentheses stuff first, and then you can subtract. 90% of copper present in plasma is bound to what protein? What is our main copper-carrying protein? Okay, so I see a few answers. It is ceruloplasmin. I don't know, whenever I see the word ceruloplasmin, I think of cereal. So I don't know, copper cereal? I don't know, whatever works for you to memorize it. The primary function of albumin is what? I see a couple guesses. This one, people maybe have forgotten on this one. That's okay. All right, so the main function of albumin is to maintain your osmotic pressure. Okay, the presence of C-reactive protein, CRP, in the blood is an indicator of what? Why do we measure CRP? All right, so I see some guesses. Good. Yep, all about inflammation. So CRP is a measure of inflammation. At my lab, they love to ask for both sed rates and CRPs together. Ugh, it's annoying. All right, haptoglobin is decreased in which of the following conditions? All right, so I see a couple of answers. It is all about hemolysis. So again, when you have your hemolytic pathway occurring, especially your intravascular one, haptoglobin is going to bind onto that free-flowing hemoglobin to keep it from being filtered and bring it to the liver. In doing so, the haptoglobin is depleted, so it becomes decreased in that hemolysis. A female patient comes to her physician with jaundice, hepatic pain, and chalky appearing stools. Lab values indicate elevated conjugated bilirubin, elevated ALP, elevated GGT. These are most likely due to what? Okay, and it is cholestasis due to gallstones. So the key here is that we knew it kind of had something in the realm of the liver gallstone area because of the jaundice, and some of this elevation. So we know that ALP and GGT we talk a lot about in the liver world. Anytime ALP and GGT are elevated, but the other liver enzymes are not, it's not something directly with the liver itself that's the problem. It's something just, it's in the hepatobiliary system that's wrong. So it's not the liver itself directly. It's kind of in that realm, but it's a little outside of there. So like your ALT will stay normal in this situation because it's not dealing directly with the liver cells being damaged. It's not the liver itself, it's something around it. So in this case, it'd be the gallbladder, all about your biliary system. So that's why you see your bilirubin elevated as well here. So ALP and GGT, when those are the only two elevated, they do go along with a lot of hepatobiliary. Fibrosis of the liver is seen in what condition? Okay, good. Cirrhosis, perfect. Increased production of blank will result in the formation of angiotensin 2, which is a stimulator of blank release. Okay. All right. So in this case, renin. So anytime you have an increased production of renin, so it'll start this whole system chain effect. So if somebody's blood pressure is high, it might stimulate the release of renin, which will form angiotensin 2, which will then stimulate the release of aldosterone. So it's a whole system chain event. A patient with glomerulonephritis would present with the following serum results. Okay, yes, your BUN would be increased. So it's obviously a kidney disease. So BUN and creatinine would both go high in kidney disease. What is the gold standard methodology for toxicology testing? All right. And it is the mass spec. If you ever watch those CSI shows or NCIS, which my mother loves, they're always putting everything on the mass spectrometer. Put it on the mass spec. I always think of that and then I always really think of that for toxicology because they're always seeing if those autopsy people have toxicology results on their mass spec. Okay, which of the following tumor markers do we use to screen, stage, and monitor? It's one of the only ones that can do all three, that we can screen for a disease, stage it, and monitor the disease with it. Good, it is PSA. It's such a great screening tool. Get done once a year after the age of 40 for men, perfect. Okay, matching. This is a little hard to do in chat box form, so we're going to just do it together. So you're supposed to match the metabolite with the drug of abuse. So you just kind of have to remember which ones go with which. Let's do the easiest one. Marijuana is letter D, THC, tetrahydrocannabinol. That's a fun word to say. Okay, so that is D. I'll just put that right there. Cocaine is B, benzoylecgonine. I might be saying that wrong, but that's how I say it. Okay, lead ethanol is A, acetaldehyde, and then heroin, I always look at the morphine part of that, is C, 6-acetylmorphine. So I always look at morphine for heroin. That's how I remember that one. So it should be B, A, C, D. Good, I was right. I'd hate to be wrong on that. So keep those in mind for drugs of abuse. Which of the following is secreted by the placenta and used for the early detection of pregnancy? All right, I think enough of you answered it. Yep, HCG. So most of us have those little wave kits in the lab that we can run, but you can also run quantitative HCGs on your chemistry analyzers to get the actual value of how much hormone they have. Which of the following is a cardiovascular agent? So now we're kind of into our therapeutic drug monitoring. So which one is a cardiovascular drug? And a lot of you probably measured this, did this, if you, yes. So it would be digoxin is our definite cardiac one out of those choices. Okay, night blindness is associated with a deficiency of what vitamin? Good, it is vitamin A, which is known as retinol, so it does deal with blindness. Scurvy, do you just want to say that like a pirate? Scurvy is associated with a deficiency of what? Yeah, so it is vitamin C. And the reason, of course, so scurvy is a disease that was a lot of times found with pirates because when they were at sea forever and ever and ever, they didn't have access to fresh fruit to get vitamin C. So they would have deficiency of vitamin C. That's why I say it like a pirate, scurvy. I don't even think I'm saying that like a pirate, but you know what I mean. Pellagra is associated with a deficiency of what? All right, this one's a little trickier for you guys. It is D, niacin. Rickets is a deficiency of? Good, you guys have that one. D, yep, vitamin D. Blood clotting is associated with what vitamin? Good, vitamin K. Menkes syndrome is associated with a deficiency of what element? Menkes syndrome. I thought this one might be a bit tougher for you guys. So you probably only mentioned it one time in chemistry 1, or maybe it was chemistry 2 when you got into trace elements, but it is copper. So if you have a deficiency of copper, it is Menkes syndrome. Which of the following is a fat-soluble vitamin? Okay, let me see a few answers. So it is letter A. So A, C, E, and K are your fat soluble. The rest are all water soluble. So A, C, E, K, ASEC is your fat soluble. Which of the following hormones plays a role in regulating water excretion? Oh, ADEC, yes, ADEK. Thank you guys. Oh my gosh, what's wrong with me? ADEC is right. A, D, E, and K are fat soluble. Forgive me. I'm so glad you guys got that on me. Thank you. Okay. I need you guys. All right. So this is ADH, which is antidiuretic hormone. The name itself, diuretic, tells you it's got to do with water. So antidiuretic hormone is all about regulating water excretion. It's also known as vasopressin. So for some reason you see the word vasopressin, it's the same thing as ADH, antidiuretic hormone. Okay, which of the following hormones plays a critical role in lactation? And it's not going to be the one that it looks like it should be. careful on that. It's not the obvious one. All right, so let's see what we have. No, don't second guess yourselves. It is the oxytocin. So letter B, prolactin, is what people always want to pick, lactin, lactation. So prolactin does have a role with milk producing, but in the way that it develops the mammary glands in those breast tissues. So oxytocin has a bigger role with the actual lactation part to it. It's very, very like gray. It's so slim of a narrow. This question is kind of poorly worded to me because it could have been B, because that does play a role with the mammary glands. But yeah. All right, so some more matching. I will just do this with you guys and hope that I'm on track with what I know. Okay, so digoxin, we've already said, is cardiac, so letter E, cardiovascular. Dilantin is B, is an anti-epileptic. Valproic acid should also be an anti-epileptic. And right now I am blanking on the other name for valproic acid. There is a different name for it. Anybody remember the other name for valproic acid? Depakote? That sounds right. Yeah. I'm like having a brain fart today. It's been a long time since I taught therapeutic drugs. Theophylline or theophylline, I don't care how you say it, is a bronchodilator. Tegretol, which is starts with a C, the other name of it. See, I'm totally blanking today. Carbamazepine, right? Carbamazepine is Tegretol. I remembered that. That should be an anti-epileptic. Chloramphenicol is an antibiotic. Prograf is a immunosuppressant. I used to measure this a lot when I worked in the Mayo system, because we'd have people that came in with like kidney transplants and they would have to get their Prograf measured because that was an immunosuppressant they were on to help so that they didn't reject their new organ. And then lithium, of course, is an antidepressant. That one we seem to all be able to remember. So let's see if I was right. Oh, good, I was. It's always a worry. Sometimes I forget a couple. But a lot of anti-epileptics on here. So dilantin, valproic acid, also known as Depakote, Tegretol, also known as carbamazepine. Those are all your anti-epileptics. So, all right. I think we're good there. So some of your labs might have measured, if you're in a big enough lab, chemistry lab, they might have measured one or two of these, maybe all of them. It depends on how big of a lab you went to. So every lab will determine which drugs it wants to monitor and which ones maybe it sends out. Okay, calcium concentration in the serum is regulated by what? Okay, good. It is the parathyroid hormone, all about calcium concentration. Major actions of angiotensin 2 include all right, so we have a few answers here. In this case, it is increased vasoconstriction. Letter D is not correct because it would cause an increase in secretion of aldosterone, because the way it goes is renin will form angiotensin 2, which will help secrete aldosterone. So the reason D is not correct is because the decreased release. Instead, it would be an increased release of aldosterone. So its other role is increased vasoconstriction. A hospitalized patient is experiencing increased neuromuscular irritability known as tetany. Which of the following tests should be ordered immediately? Good. I had a feeling you guys would do well on this one, calcium. The other one that you could also order for tetany that's not on this list is magnesium. So magnesium is the other one that we might see ordered for tetany. The parent substance in the biosynthesis of androgens and estrogen hormones is what? What helps make those androgen and estrogen hormones? Good. It is cholesterol. That cholesterol has a lot of roles in our body. It's amazing. Which of the following readies the uterus for implantation of an embryo? Which one gets that uterus ready? These hormones are always tricky for people. So it is your progesterone. So the way I think of it this way is a lot of women who struggle with getting pregnant will maybe get on a regimen of progesterone shots. And that's, again, to help that uterus with the implantation for that embryo to help them get that pregnancy. So I always kind of think of it like that. Which of the following aids testosterone in spermatogenesis, in the creation of sperm? Which hormone helps do that? Okay, so I think I see a few answers already for this one. So in this case, it is your follicle stimulating hormone, FSH. So I know FSH does something in women and does something in men. In this case, in men, it helps testosterone create sperm. So whatever you can do to memorize that, it's follicle stimulating hormone that does that role. I don't think I have anything great to help you with that. All right, which of the following stimulates production of testosterone by acting on the Leydig cells? I don't know how you say that word, but I always like to say Leydig. This one's a little nicer when they include the cell name because we can put the L's together. So yes, luteinizing hormone will help make testosterone from those Leydig cells, L for L. If they don't include the cell name in there, you still got to remember that LH does help make testosterone. TSH, thyroid stimulating hormone, is produced by what? All right, I think people have answered this one. Yeah. So it is made by the pituitary gland. So it's released from the pituitary gland and then will go and stimulate your thyroid. But there is a whole, before I jump off this, I would just say there is a whole chain of events. The hypothalamus releases a hormone that will tell the pituitary gland to then release the TSH hormone. So it's like a chain event. But TSH is coming directly from pituitary. Okay, so we have to match the hormones to the gland that secretes it. So all of these come from the pituitary gland. So we already know that. Most of them come from one part and 2 of them come from the other part. And we're just going to go ahead. And if I remember correctly, oxytocin and vasopressin are the 2 that are the oddballs. I think they come from the anterior. Right now, I can't for the life of me tell you, so I want to just look at the answer without confusing you. So yes, vasopressin and oxytocin are the 2 that are different. And oh, they come from the posterior. See, I did have it backwards. It's been a minute. So those 2 are housed in the posterior pituitary gland. All the rest, the growth hormone, the FSH, the LH, and the prolactin, all come from the anterior pituitary gland. So, okay. Again, it's kind of a memorization thing on that. Match the disease with its corresponding definition. These I thought were always super confusing, knowing which one is Cushing, Cons, or Addison's. So let's go ahead and take a look. Cushing's is all about excessive cortisol. So in this case, they say corticosteroids, so extra amounts of cortisol. Cons is too much aldosterone. Addison's is too little aldosterone. So that aldosterone hormone, the whole function of that, I don't think I've mentioned it yet, is about sodium regulation. So aldosterone is all about helping with your sodium regulation. So in Addison's disease B, it's hypoaldosterone. So they're saying they have little aldosterone hormones. So that will affect how much sodium they have, and then how much sodium they have will affect how much potassium is available too. So it does have a trickle-down effect, but you should know that the aldosterone hormone does go along with sodium levels. Yeah. Jenny's babies. I got you now on that one. Okay, took me a second there. So this is just kind of a memorization thing again, knowing which name. Cushing's to me has always been a bit easier because I always knew that was high cortisol. It's the Cons and the Addisons, remembering which one's hypo and which one's hyper. I will say this. I want to look up something. I know, kind of venturing off here, because I think it's important, because I know in fact, there's questions on the board that could have this. I thought I have it somewhere in a PowerPoint, but it'll take me too long to find the PowerPoint at this rate. So again, okay, so low sodium and therefore a high potassium will indicate Addison's. So when you look at this question, so like I said, if you have Addison's, you have little aldosterone, so therefore you have little sodium. So anytime your aldosterone is low, your sodium is low. Because you have little of that cation, you're going to have a lot more of the other cation, potassium, and potassium will go high. So in Addison's, your sodium is low, your potassium then would be high, because that's your other cation, so it would have too much of that available. So, so the opposite is true Cons. If you have a lot of aldosterone, you have a high sodium and a low potassium then. So you do kind of have to know those sodium potassium results along with which one has low and which one has high aldosterone. So always keeping in mind what aldosterone tells us and what it does along with that. All right, Dallas has, oh my goodness, flat peg, FSH, LH, ACTH, TSH, prolactin, endorphins, growth. Those are all the anterior. There you go. A flat peg is all your anterior pituitary hormones. That works good. You can have a flat peg in your anterior to put it all together. Good. Thank you. I love helpful things like that. That's kind of the name of the game, is how to keep it all in your mind. Okay. So now that we've spent some time on this, let's move on. An oncofetal antigen commonly used to assess the recurrence of tumor growth following removal of a colon tumor would be what? So which one of these do we measure colon tumors? Yeah, you guys have this one down. You probably already know the saying with it. If you don't, I'll give you it. Again, it is not a nice saying. I didn't make it up. It was not me that made it. So, clarifying. So, colon tumor, CEA, if you think of C as cancer-eating ass for colon. That's the one way you can remember it. I did not make that up. So, but people seem to think that's helpful. Okay. Which of the following is the most common cause of hypothyroidism? Okay, I have a couple answers. Let's take a look. and it is Hashimoto's thyroiditis. So Hashimoto's is the most common cause of hypothyroidism. Okay. All right. Fasting serum phosphate concentration is controlled primarily by what? What controls our phosphate levels? Oh my gosh. Okay, let's see. Okay, so I have a couple answers. Let's take a look. It is parathyroid hormone or glands. So the parathyroid is responsible for controlling your calcium level and your phosphate level, and they have an inverse relationship. So when calcium goes up, phosphate goes down. When phosphate goes up, calcium might go down, and that's all controlled by your parathyroid. Okay, so that is, oh my gosh, that is it for our questions. 185 slides. So basically about 90 some questions because half those slides were answers. That's a lot of big review. So what you should know for chemistry is know those calculations, especially for your boards. And then just kind of re-look at the areas that maybe you're weak in chemistry. You guys need to do really well blood gases. So I'd say you are starting to get that down pretty well. Maybe you're weak in electrolytes, like which diseases cause a high potassium or low potassium, which one causes a high sodium or low sodium. Maybe it's your liver enzymes or stuff like that. So kind of go through and then just kind of try to target your weaker areas if you can. So the other thing is, hopefully you guys all have that board study guidebook. Use that. Keep quizzing yourself out of that. Media Lab online is always helpful. Use that all you want. You have it for a year. So your subscription is good for a year. Keep using that. The other thing that students have found it really helpful is, I will say about Media Lab, microbiology in Media Lab is a B. It's so tough. There are so many dang organisms that you're like, what is that bacteria? I've never heard of that because there's so many. So don't get down on yourself about the microbiology section on Media Lab. If you're like, this is so tough, it is. Yeah, because there's a lot of bacteria. So just letting you guys know, I've heard that from a zillion students, that is a hard section on Media Lab. But the other thing is, and maybe you guys have already been told about these or have them, there are cards that you can get off of, and there used to be, hopefully she still has them, Valerie Polanski on Amazon. So hopefully you guys can still see my screen for Amazon. The quick review cards from Medical Lab Science. So see, it says bestseller. Buy new in stock. Yeah, $40. So they cost $40 to get the actual cards. You want the real cards, not the Kindle version. You want to see them in person. I have these. I have had students who studied only from these and did really well on the boards. They also have had students that use these, plus the board study guide book, plus Media Lab, and did very well. So it's all depending on how you learn. The nice thing about these cards are, if you haven't seen them in person, is it has each department separated. So for chemistry, it will list your sodium. It will give you the normal reference range for sodium. It will tell you the diseases sodium is increased in. It will tell you the diseases sodium is decreased in. Then we'll have potassium, and it'll do the same thing. Chloride, same thing. And it will have ALP, AST, ALP, bilirubin, you know, so on and so forth, like albumin, glucose. It will do that for every analyte you can find in the chemistry area. So they're kind of like flashcards, and I've had students use them to highlight areas. They're great for microbiology. They'll give you like a bacteria, say like strep pneumoniae, and they'll tell you, oh, it looks like this on morphology. It gram stains this. Here's the biochemical results. It's catalase negative, opticin susceptible, biosolubility positive. It'll give you that for each bacteria organism. Blood typing, it has transfusion reactions on there, how to interpret different blood types. Incompatibility, ABO incompatibilities that might arise. It has so much good information in each department area. So I always say they're amazing because they're in flashcard form, and you can highlight and write on there and use them as you want to. So it's just kind of what I recommend. I always look at Valerie Polanski and see a lot. Otherwise, you can memorize it as quick review cards for Medical Lab Science. So, yeah. if you type in Polanski cards, free PDF in Google, you can view them. So yeah, you can kind of view what they look like in Google. That's a thank you, Dallas. So you can kind of have an idea, because they don't give you any pictures here in the Amazon review of what they look like. So you could try that just in Google and try to see what they look like if you want to spend the $40. The other resource, and I'm going to see if it's still available here. It was one that I learned of a few years ago. I haven't always known about this. I don't think it was always available. I have never used this myself. So I can't tell you from personal experience. I've never viewed it, but I've had students use it, a couple. So there is a website called ASCP.com, and you saw I went to it, and I clicked on medical lab technician. And so technically, I don't know, maybe this isn't here anymore. Oh, it may be for sale. Oh, you know what? This used to be a quiz website where you can go and take quizzes. I wonder if they shut it down now. Okay, scratch that. It doesn't look like it's what it used to be. That's a job, that's instrumentation. Yeah, this isn't any longer. I was wondering because I had only heard of it a couple of years ago and it doesn't seem to be up anymore. So never mind. Don't worry about that. Keep using your board study guidebook, use your Media Lab, and then if you want those Valerie Polanski cards, they're great help too. So otherwise, I am done. I know you guys have Tammy tomorrow for blood bank stuff. She will also go through ASCP, like board stuff, how the process works, how we, apply for you, that kind of thing, answer questions there. And then I will be back with you guys Wednesday morning. All right. So that is it. I will send you guys the recording and the PowerPoints we use. I'll send you that extra PowerPoint too that I referenced for blood gases in case you found that helpful. Just know that it will take me a little bit to get this recording link available because I have to process it before I can get it. So I might not be able to send you this link until tomorrow sometime. So just be patient with me. I will get it to you. All right, that's all. Otherwise, you guys have a good night.